No, you're very welcome. On behalf of Athlone Literary Festival, we'd like to welcome you to this afternoon's discussion. I'm delighted to welcome Dr Terry Lynch from Limerick. Many of you know him. He's a psychotherapist and GP who has worked exclusively in mental health over the last 10 years. You may be familiar with his books, Beyond Prozac and Selfhood, which is a remarkable workbook. And he's going to be interviewed today by Dara White. Dara is from Athlone and he is an environmental engineer. He has experience of depression and has worked through that, through breathwork and through studies with the Jungian Institute. And he's very involved in Renew, a peer-to-peer support group for people experiencing mental distress.
Thank you, Jackie. Okay, for me, this is really exciting because I read Terry's book a number of years ago and found it Beyond Prozac and found it very illuminating in terms of mental illness, mental wellness. So to be actually here having a conversation with Terry is a great honour. And then to kind of follow through with the book on selfhood, and I know Terry has other books coming. So it's kind of working in a journey with Terry on this, so it's exciting to be here. And just when I was doing some background research on Terry, I kind of came across a number of references or commendations by a couple of psychiatrists here. Professor Ivor Brown said this of Terry: Terry has consistently called for a reappraisal of how human suffering and distress is interpreted and responded to within modern Western societies. A reappraisal that I support, that I believe is urgently required in the public interest, and would that there were more enlightened doctors and psychiatrists working in the country. And then Dr. Pat Racken, psychiatrist down in Cork, said Terry became disillusioned with the way many of his patients, the mental health aspect of general practice, were being handled. And Terry, being a true scientist, started to read the literature and started to become aware that a lot of what was being presented as the science of psychiatry was in fact pseudoscience. So with those two thoughts in mind, Terry, I'd just like to bring you to your practice, the kind of core of what you're doing, which is working with people in mental distress. So if you'd maybe like to take us through some of what you do, maybe focusing on depression to start with.
Sure. Thanks very much for having me today. It's a real honour for me to be involved in this literary festival, and thank you very much, all of you, for coming here. The title of this discussion really, I think, symbolises a journey, and mine has been a journey too, as Dara touched on. As I was saying to Dara earlier on, in my early days as a doctor, I was a very, very committed doctor. I believed in my training deeply because I just believed it. This is what we did as trainee doctors. We believed what we were trained in. But then as I was working with people as a GP, people's stories didn't quite fit with what I had been trained. And I began to see that there was actually a whole other area of understanding that I knew very little about as a doctor. So I just went about re-looking at this, reappraising the whole thing. And that took me on a journey which has led me to here, and I'm sure it'll go on a lot further than that. And it has taken me to a very different understanding of emotional and mental health, including what is called mental illness. And I work in a very different way. And for about the past 10 years now, 12 years, I've been working in what I would describe as a recovery-focused mental health service. And for the past 2 years, my partner and wife, Marianne, works as a psychotherapist with me. But it's a very different approach to the medical approach. It's very much based on the premise that actually experiences make sense. All human experiences make sense. They're all purposeful. And that long ago I began to question the whole categorization of normal and abnormal, which is what doctors tend to use as their standard, I suppose. You know, is this normal or is that abnormal? And I found that actually, if you listen carefully to the context of the person, that every story is normal. Every story makes sense. And all experiences make sense. And that's my starting point with people. And I have learned that people with depression, bipolar disorder, people who've had those diagnoses, that actually I personally question them as being mental illnesses. I see them as experiences. I think that's a better, more accurate starting point. And from that then, there are different possibilities. So I join with the person on a journey, really, where I try to get to know them and they get to know me. And we basically embark on a journey where the person has the opportunity to tell me their story. I try to make sense of it with them. Making sense of a person's experiences and stories is enormously important. The majority of people who come to me have already had a diagnosis, usually by a psychiatrist. And what I have found is that I can generally make sense of the story, whereas previously they've just been told, well, that's a sign of mental illness. And there's no understanding in that line that it's mental illness. And knowledge is power. And when people become not more understanding of their own experiences, people are more empowered to actually take more power and control of what they're going through in their life in general.
Lovely. If you just, give me an idea of the type of people that come to you with labels, and maybe what,
Sure.
how you've worked with them or what has happened, or.
Sure. The majority of people who come to me, I'm a medical doctor and a psychotherapist, but for the past 12 years I have not worked as a GP. It's just pure mental health. The majority, I would say probably 90% of people who come to me have had a diagnosis made by generally a psychiatrist of either depression, bipolar disorder, schizophrenia, obsessive compulsive disorder, eating disorders. They would probably be the main ones. And I always start as if it's a clean sheet. I'm never fazed by a person having a 10-year history of bipolar disorder. To me, it's a story, it's a person. I want to hear their story and see where there are areas that we can look at and work with. And for example, as I was saying to Dara earlier on, at the moment I would have probably 6 to 7 people just at the moment with a diagnosis of bipolar disorder who are either off medication and attending me as follow-up just to make sure that the landing is a safe landing, or who are at a much lower level of medication than they were at. To me, the whole thing of recovery isn't about necessarily coming off medication. It's not that simple. It's about recovery of rather than recovery from. Recovery of one's sense of self. Recovery of one's confidence and ability to deal with the world, to deal with the everyday stresses that we meet in this world. To me, what is called mental illnesses is actually much more accurately looked at as problems of living, problems related to life. Life is tough going, and it's got much more tough in this country over the past few years. So I have just a very different starting point, and that then can lead to different outcomes. I believe in being truthful to people, and I'm truthful about medication, for example. Medication has a role. Without question, it has a role. But I will never tell somebody that they're on a medication to correct a chemical imbalance, because chemical imbalances cannot be established. There is no way to establish a chemical imbalance. So if I tell somebody that they're on medication to correct a chemical imbalance, that to me is an untruth, and I will try hard not to convey an untruth to people.
So are you, just to follow on the chemical imbalance thing, are you saying that there's no way of establishing that there is a chemical imbalance, that the serotonin in the brain is, not measurable?
Exactly. Serotonin in the brain is not measurable, full stop. Which is why nobody with a diagnosis of anything ever has that diagnosis confirmed with a test. So at best, it's a hypothesis. So we can't say for sure it's not true, but we most certainly can't say it is true either. And I find in my work, I suppose one of the things I try to bring to my work, which wouldn't be typical of a doctor, is a more expansive approach. Generally, doctors look at people and their experiences from a biological perspective. To me, other stuff is far more useful and workable. The emotionality of the individual, how they think, how they feel, their story, their experiences, the context in which their experience have arisen. I find those areas far more fertile ground to actually make some progress than hypothetical ideas about chemical imbalances that I can do absolutely nothing with or about in the room with the other person. It's utterly theoretical, so it's of no help to me in my work with people. To me, the whole thing of chemical imbalances is misinformation. If a person is told they have a chemical imbalance, that's misinformation because it has never been established. there are a number of threads to this whole mental health area that I'm very unhappy with, and misinformation is one of them. There's a great deal of misinformation out there on mental health, and that disempowers people and disconnects people in a way from the potential to actually progress.
Right. Just taking the discussion on the chemical imbalance, and what we do then is we typically, and I'm not saying not in all cases, you're offered medication.
Yeah.
And you're offered medication. Normally, it's well, depending on the so-called diagnosis, for life.
Yes.
Can you talk to me a little bit about the kind of background of the research that you covered in Beyond Prozac on that notion that medication is okay, or what the research, or how the research was developed, and how
Sure.
good or useful it is?
Yeah. I suppose I try to keep things simple, and to me, if you look at what people do, it generally tells you more than what they say. And in any mental health condition, there are no tests ever done, ever. Depression, bipolar, schizophrenia. So that tells me something. There are no tests because no abnormalities have not been identified. And what's actually happened, if you take depression, for example, or what's called depression, it was found many, many years ago that the drugs that are currently called SSRIs, they interfered with and by the way, medication has its place, so I don't want anyone to think that from my talk today I'm saying people should not be on medication, or that anyone should stop their medication based on today's talk. This is not a specific advice talk for any individual. We're talking generally here. Because coming off medication without proper supervision and advice can be very problematic. But actually how the whole thing has come about is that the SSRI drugs were found to interfere with the reuptake of serotonin in the space between brain cells, yes, the space between them, called the synapses. What has never been established is that a good thing or a bad thing? That's all that the science has shown, that the reuptake of serotonin is interfered with. And from that premise, and because the medication seemed to make some people feel better, the premise was, well, they must be feeling better because they had a deficiency of serotonin to begin with. Well, that's a bit like saying that if I take aspirin for a headache, that the reason I feel better is because I had a deficiency of aspirin to begin with. It's flawed logic. But upon that, the entire industry of prescribing of antidepressants is based. And to me, that's a very flawed basis. Now, medication does help people, but I have found that because I have expanded my understanding of what people are experiencing and also expanded, I think, what I can do with people, I don't need to reach for the prescription pad nearly as much as the majority of my colleagues.
Yeah, and you're very clear about that medication has a role. But it's not medication on its own. It's medication and support and, as you say, reference to the experiences that has brought the person to that level of distress. Yeah,
and again, key question to me is, from a scientific point of view, what is the medication actually doing? And what people will generally tell you is that if they do feel better on medication, is that it's numbing something. It's numbing the pain, which has a role, or it's making them feel a bit more relaxed, for example, and that has a role. But my hunch is that those actions should be kept as short-term as possible, because if they're continued long-term, then the person can develop at the least a psychological dependence on what the tablets are doing for them. And it's taking the focus off where the focus needs to be, I believe, which is on looking at what's going on in the individual, the hurt, the trauma, the defense mechanisms they've created, the distress they're experiencing, and how they handle everyday life. That, to me, is where the focus is most fertile.
So you were saying, like, if the pain that we're suffering, like when I'm depressed, I was suffering pain. Mm-hmm. The way to work with that is, if it's very bad, maybe a bit of medication would stabilize me, help me. But I really need to kind of put in perspective that suffering. And we are afraid to do that, or we're...
Yeah, my starting point is that everything makes sense. So if a person is quite depressed, that makes sense at some level. So I don't try to take that away from the person unless it's causing so much distress that they really do need a break from it.
Yeah.
But to me, there are a number of things. That person needs to generally work their way through whatever it is that's going on. And often it involves actually expressing the emotion to its completion, to its endpoint. We live in a society where our emotions generally are not considered healthy to have what are called negative emotions. John McCarthy, some of you might have heard of John McCarthy. He was I suppose, director of Mad Pride and a great campaigner for change. And I came across a quote from a book he wrote a number of years ago called The Human Condition. And it was, it was about, is it time for change? And the first line was, is it time to decriminalize human emotions? And I thought, what a great line, to decriminalize human emotions. And we've kind of done that, you know, we've kind of we've kind of said, okay, you know, if somebody is very, very frightened and looks very, very frightened, generally other people want them to stop being so frightened. If somebody's deeply in grief and crying a great, great deal, a lot of us will feel very uncomfortable and we kind of want them to stop. Perhaps because they may help us tap into our own pain, perhaps. So it's part of a broader societal denial, I think, and avoidance through fear of our own pain and distress. And I think if we as a society had a different approach to who we are as human beings, then we wouldn't, to use John McCarthy's phrase, criminalize human emotions and put them away into a box. Because what can happen is if we're overcome with emotion and pain and distress, where are we to go? You know, we end up being boxed away too, with our feelings. And that's a huge part of the whole stigma of mental health. I mean, there's a lot of work being done on stigma, but in my opinion, you've got to get to the core issues. And the core issue, I feel, is at the level of we as a society, not just in Ireland, it's a Western phenomenon. It is not okay to feel intense pain. And I think until we grow up and as a society and say, you know what, it is okay. And not only is it okay, it's actually very, very healthy and healing. That is urgently required.
So you're saying it's beneficial to go through this, to face this pain, to work with it, and then to see what comes out the other side. And I think that's what you address in the book, Selfhood.
Yeah. Well, if we have the pain,
yeah.
And if we don't actually work our way through it, then we stay stuck, and it stays stuck.
Yeah.
And this is one of the problems about medication sometimes. Yeah. You know, medication can be beneficial and it eases that distress, but it also kind of keeps it numb and anesthetized and still and stuck inside us. And I don't think long-term that's the way to go. I mean, in my work, I'm always kind of attuned to grief and sadness. I think the whole thing of loss in society is very, very underestimated. Loss is far more common and far more universal than we might think. And loss is cumulative. And a lot of losses are very private to the individual, and other people may not realize or see the significance of the loss for the person. But when I'm working with a person, it doesn't really matter what the diagnosis is, I'm actually very happy to see people come into their grief and deeply get into their grief, because that is healing and that is releasing. And it's often an essential part of the journey of recovery. But again, grief is not something that as a society we consider an okay place to be, unless the reason for that grief is very clear. So if somebody's, for example, lost their loved one, and they're in grief, well, we're okay with that. But lower levels of cause of grief, generally speaking, I think the way we work is, if a person doesn't understand why the other person's grieving, then it doesn't seem to make sense to them. So that's not what empathy is. Empathy is where you get inside you can understand where the other person's coming from. But a mistake that's commonly made in society is that we evaluate, and doctors make this mistake as well, we evaluate other people's experience from our place. And that is not the way to evaluate people's distress. For example, somebody who has a tendency to what might be called a high. You know, a doctor looking at that is evaluating it supposedly from an objective perspective, from their perspective. But the person's in their own perspective. It's a different world completely. And to me, the real skill is, can I get inside the world of that individual, and can I understand why that makes sense? And I usually find I can. And then we can really connect.
So that's what you were talking about, accurate empathy?
Yes.
So you, by being accurate and being empathetic, you're allowing that person to space without sort of non-judgmentally?
Yes.
To kind of explore their own, I was going to say suffering, but experiences.
Yes, absolutely. To actually have a forum to put it out there, because in our society, such places are few and far between, where people can actually, I mean, where can a person go to discuss going high, for example? Where is there a forum to discuss that for an hour without somebody coming in and stopping them and saying, well, actually, that's a sign of sickness, and we'll stop it there, and we'll put you on medication. And medication has its place, as I said. But if we're going to resolve stuff, we have to give it a full airing, and then the sense of it will unfold. That's what I find all the time.
And other symptoms, like we talked about earlier, and about hearing voices.
Sure.
You know, and it's probably a lot more common. In fact, I have a voice inside my head all the time. Mm-hmm. And I know when it's discussed about, it's actually a projected voice. But still, it's just an experience.
Yes.
And can be worked with.
Yeah. About 10 years ago, I spoke at the British Hearing Voices Network, and the thrust of my talk was, I suppose, normalizing the hearing of voices. I hear voices, I hear my own voice, and I know it's my own voice, and usually it's in the first person. I this, I that. If I'm cross with myself, it goes into the second person. You bloody idiot, or whatever it might be, you know. But the only difference really with the voices I hear and the voices that people who have a diagnosis of schizophrenia is that the voices are generally in the third person. They're a he or an unidentified voice. In theory, an unidentified voice. But I've seen, and there are many people around the world who have realized this too, actually that fits perfectly for where that person tends to be at in themselves, because quite often their sense of self is fragmented enormously. And if their sense of self is fragmented, and if they have experienced trauma, and trauma, in my opinion, is grossly underestimated too, just like grief is in our society. So if people are traumatized and wounded and hurt, and their sense of self is fragmented, then it makes sense to me that the voice, what's going on in their mind, will reflect that. And it's often voices are often a very accurate reflection of the drama and the difficulties that the person is experiencing. They're often very metaphorical. They make sense, but maybe not at the literal level of the voices. I can think of somebody not too long ago who was coming to me and was hearing voices, and as we were talking, it was early in our work, and the person said, oh, they're outside the door, they're outside the window. I said, oh, yeah. What are they saying? And one voice was saying to the other, aha, she's getting help now. It was a direct reflection of what was going on in her life. And that made complete sense to me. So I think we're making a very serious mistake when we pathologize human experience without taking the time to see, does it make sense? Because the starting point is critical. If as our starting point we abnormalize, we're going down this pathway. If our starting point is, let's try to make sense of this, then that takes us down a very different pathway.
A completely different view, in fact. And you're sort of saying, that, if I'm understanding it correctly, like the degree of, you know, taking voices as an example, kind of, you know, the voice I hear, then they're going out to kind of third person or whatever, is a separation or a kind of a movement away from sort of selfhood or a loss of selfhood?
Yes, it's a reflection of the loss of selfhood. A word that's sometimes used, I think, for such experiences, disassociation. And disassociation is a trauma reaction. It's a reaction to trauma. And, you know, I see in my work all the time the evolution of trauma in people's lives. And we think of trauma as the very, very big things in our society, you know, awful things happening to us. And that's true, of course they're trauma. But we're fragile human beings and we get traumatized quite easily. And the definition of trauma actually is something that has caused us emotional and psychological damage which has not been healed. So it's unfinished business, really, is actually the definition of trauma. And when you look at it like that, most of us have unfinished business. And I'm not exaggerating it. It is what it is. But the word trauma in our society is thought of as, oh, it must be a terrible thing. And of course, terrible things cause trauma. But we're traumatized, I think, as human beings, a lot easier than we might realize. And I think, I was saying this to Dara earlier on, it struck me in recent times how the thresholds for diagnosis of mental illnesses are very low. So, the information we are told is that up to 1 in 4, or more frequently even, one in 4 people in their lifetime will suffer from a mental illness. So the threshold for diagnosis of a mental illness is quite low. But the threshold for the diagnosis of trauma is very, very high. So not that many people at all will qualify, in medical language now I'm talking about, for a diagnosis of trauma or post-traumatic stress. Post-traumatic stress requires that you have things like either you have witnessed somebody being very seriously assaulted or being assaulted very seriously yourself. The bar is very, very high for trauma. And I find that very interesting. And similarly for grief, as I said earlier, the bar is set very high for grief. And distress, which is something that is universal, in medical terms, distress is kind of dismissed as not that important. It's illness matters, not distress. And I think it's no coincidence that mental illness, the threshold is very low, but for all the others, the threshold is either very high or it's irrelevant. And I think we have to change that. To me, the concept of mental illness is seriously flawed, and its very existence, I think, needs to be questioned at a very high level, I think. It may take an EU inquiry to really look at that seriously. But trauma, hurt, woundedness, distress, defense mechanisms too. A lot of what people diagnosed with various mental health diagnoses, a lot of what they're going through is defense mechanisms. They're defending their woundedness. And that, I rarely hear doctors talk about defense mechanisms. I read medical journals, I listen to doctors. I rarely hear that. And I certainly think GPs don't understand much about defense mechanisms, because the way GPs are trained in mental health is not adequate, in my opinion, at all. But I rarely hear psychiatrists talk about defense mechanisms either. But whether in bipolar or schizophrenia in particular, defense mechanisms are a huge part of that experience. And it's defense from further hurt or woundedness, because I already feel so hurt and wounded. And to me, language matters hugely. I rarely use medical language. I don't feel the need to use medical language. It's elitist. It disempowers people. And I think there's no need for it. Ordinary English works just fine.
Thanks, Terry. Just following up on the notion of kind of trauma and, as you say, being diagnosed, or high level here, but actually, in fact, we experience it a lot more. And you hear a lot on some commentary is that it's, particularly with a difficult trauma like a sexual abuse, that you never recover.
Yeah.
Have you worked with that, or that your experience of deep trauma, and the notion of recovery?
I think one thing I did learn in my medical training was 2 words that one, as a doctor, should not use that often, are always and never, because they're too definite. I think clearly the more traumatized the person is, obviously, the harder the process of recovery will be. But there's so many different factors that come into it. Factors like how much support they have, to what degree is their sense of self affected, and just how trauma is very personal. And that's one thing that I think the whole mental health field needs to look at as well, is what I call the personal private world of the individual. The way that person has learned to process life, to deal with things, how they think, their habits and patterns. I think that one of the problems, is that our responses to trauma in this society are very inadequate. And they're inadequate because, for the same reason, really, that trauma is not valued to anything like the degree that it should be. And I think if we had a service that made trauma and distress at its heart, then we would cultivate the type of services that would be far more effective at helping people with deep trauma. I would certainly never have the I would not think that, and in my experience, that there are some people who cannot be helped. I don't think that's true. But clearly, the deeper the wounding, the greater the challenge for healing, yes.
Yeah, so just following up on that, on the trauma, and I mean, you clearly said there a couple of minutes ago that in your view, you're questioning the whole basis of the idea of mental illness.
Yes.
And I know in my case, like when I was depressed, like it was very difficult at the time, but now looking back on it, probably one of the better things that had happened. It changed my sense of self, my worldview.
Sure.
And as a society, we seem to be holding this idea of mental illness. And what you're suggesting is to kind of broaden it out, change that view, have a bigger view,
Yes.
and that suffering is a natural response that can be worked with and things will change.
Yes, absolutely. I think that, as a human right, people have a right to accurate information. And I think that there has been a lot of misinformation put out from the drug companies and from the medical profession about what is called mental illnesses. And this has led people to think about distress in a particular way. And the whole playing field needs to be revised. And by focusing so much on mental illnesses, I believe we've been going down a cul-de-sac, which really doesn't hold the potential to learn and to grow and to heal that we would have if we actually dealt with what it is people are experiencing. I mean, that's another very important point. What the medical profession does is it interprets people's experiences. And it interprets them in a particular way. I think in the first paragraph of Beyond Prozac, I wrote repackage, that the medical approach repackages human experience and distress into illness. Well, that's the first step that takes us way off track. And I think that if we bring it back to what it actually is, it's much more workable. And another very important point, I think, is that we have tended in medicine to make things permanent. You kind of alluded to this earlier on. In the last few weeks, I've had 2 people coming to me who went through what could be, I can understand why they would have been called psychotic type experiences, but they've actually recovered very well. And one person was with me recently and back at work, and there seemed to be a strong inclination within the services to just keep harping on the fact that she had this experience, rather than focus on the immense effort she had made to recover, and was back at work and deserved a great deal of support and validation for what she was doing. So to me, what people go through, whatever it might be, needs to be seen in its own context at that time. It's an experience at that time, but because somebody goes through a psychotic experience now does not mean that they should be on medication for the next 25 years. That can be worked with. It is a scenario that has evolved for good reasons at that time in their life. And if the person receives the right support and the right environment to work through what it is they need to work through, they can come out the other side. So that is one thing I really question in terms of medicine, is how it has made things kind of permanent and long-term. I don't see it like that. Emotions and emotional situations are generally transient. And sometimes we can actually interfere and stop something that, if we actually facilitated it, could come through to a healing ending, if you know what I mean. Sorry, I may have gone off track. I'm not sure.
No, that's on track, because, I mean, if you go back to what we were just talked about over lunch, one of the, I referred to John Weir Perry and his notion that, people can go into, and I don't like the word a psychotic experience, but if it's allowed come true, like you've just described, that the person, and these were his sort of words, was that the person would kind of come out of it functioning at a higher level.
Yeah.
So there's not a reintegration, an integration at a different level.
Mm-hmm.
So as a view, what you seem to be saying is, as a society, we need to take a very different view.
Yes.
That if something like this happens, we should almost celebrate it.
Well, not sure what celebrate. I mean, there would be plenty of times in my work where I'm working with someone who is at the edge. And there are times when people I'm working with need to go to hospital for a number of reasons. Yeah. So I'm not anti-hospital either. It has its place. But kind of like what you're saying there, Dara, when the person's in hospital, I'm generally not involved, although I can be. Sometimes the person wants to stay in touch with me. But usually when they come back to me, if they come back to me afterwards, we look at what happened and we look at the learnings from it. And there are always learnings. And that can be very, very helpful and very, very useful to learn from how did that happen, the dominoes that fell, one, bang, 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 one by one, that led to that can help the person become more aware of the steps that led to that. So maybe next time it can be addressed and stopped sooner. And there can be a whole range of steps. Sometimes there have been a number of people who didn't contact me, for example, when they were on that slippery slope. And they have learned that actually, if they make contact with me, we can address it much quicker. And medication can be very, very helpful at those times. But absolutely, I mean, the learning that is in these experiences, in my experience, is enormous. The potential to learn and grow is enormous.
I'm going to change the subject slightly. Two things I'm going to go to. Just a very difficult subject, but it's something I'd like to address a little bit, is about suicide. It is a big issue in our culture, and particularly with, well, it seems like a lot of young people.
Sure.
And, as is happening, a lot of older, men at the moment. I'm just wondering, from your perspective, your work, is there anything that your experience would bring to that?
Sure. I think one thing that I would do quite differently to most doctors would be, if somebody comes into the room and says to me, I feel really suicidal, I'd say, okay, let's talk about it. And we might talk about it for 40 minutes or half an hour or an hour, so the person can actually voice what they're going through. Usually with a doctor, if it's mentioned that the person feels suicidal, generally the conversation kind of stops at that point and action is taken. Now, quite often, it's very necessary for action to be taken. And I'll often take action with people in terms of sending the person to hospital if that's what's required. But we have created, kind of along the lines of what I was saying earlier on, we've created a society where distress and pain we're in denial, I think, to a large degree, about pain and distress. And I think we're in denial about aspects of suicide as well. I think as a society we have great difficulty with the idea that some people may choose to leave this world. And I think we need to see that for what it is. Now, it's often said about suicide that it's an impulsive action, and that, if the person had a chance to rethink it, that they would change their mind. And I'm sure that's very true. But the impulse in itself is real too. And I don't see the biological approach to suicide solving that issue. There's far more to suicide than the biology. It's so much about our humanity, our experience in this world, struggle, issues of meaning, purpose, where we fit in, and again, back to how we deal with pain. Say I feel deeply suicidal. Who can I talk to? Can I talk? If I'm lucky, I'll be able to talk to a good friend. Who can a 14-year-old girl talk to about feeling deeply suicidal? I mean, who can I talk to with a person who won't be thrown completely within 3 minutes?
Yeah.
There's a place, of course, in that situation for hospital, and there can be a place for medication in that situation. But I have found in my work over and over and over again that if a person has an opportunity to actually get it out, talk about it, and quite often I find if a person does truly feel suicidal, that they will cry, they will get upset, and again, that's part of the healing. There's movement. Where there are tears, there's movement. And quite often, at the end of an hour, the person doesn't quite feel so suicidal. And also, in their work with me, they've realized there is someone. There actually is someone I can talk to, or I can ring, or I can text. And I find people can text me, people can ring me after hours. I don't have an issue with that. But what I have found is that actually very few people do that. Just knowing they can actually is enormously helpful. I find very few people take advantage of that. It's always genuine when that does happen. So again, we're back to a reappraisal of what it is we're talking about here. It's pain, it's distress, it's about our humanity. And it's also about communities. Our communities are not as closely knit as they were 30, 50 years ago. Many villages and towns 50, 60 years ago, people in distress were kind of embraced within the community. Now, the whole area of mental health has become associated with fear and mistrust of people. And to be on the other side of that, the stories I have heard of people who have felt mistrusted and the stigma and the pain of that. So what a lot of people end up with is actually two sources of pain. There's the pain that got them into the diagnosis in the first place, and then there's society's reaction. You know, I mean, if I've had a diagnosis of schizophrenia or bipolar, for example, and I'm having a cup of coffee with a group of people that I don't know very well, and we're talking about ourselves, and I say, actually, well, I've had a diagnosis of bipolar, the conversation is going to change immediately because of our preconceptions of these conditions, and I think of these experiences, and I think the medical model has a lot to do with that. To me, it's all about human experience and expanding what we consider our range of appropriate and understandable experiences. I was looking at the website of the American Psychiatric Association last week for a book I'm writing on depression. And on that site, it says, depression, for example, depression is never normal. And I thought, how wrong you are. Yeah. Depression is never normal. And I look to the leadership in medicine, and I keep finding myself saying, I don't see the wisdom behind what you're saying. I don't see enough wisdom in what you're talking about to lead this area. How on earth can you believe that depression is never normal? Is that the level of training and human understanding you have, that you think depression's always normal? And these are people who we as in our society have given so much power and so much authority to tell us about ourselves. And we need to take back our power, I think. And we need to question people and say, well, what is your wisdom? What wisdom do you actually have? Why am I taking these tablets? What is it doing in my body? What is it correcting? I mean, the whole thing of serotonin is a very good example of that. If I did a straw poll of everybody in this room, or probably of 1,000 people in Athlone, if I walked down the street and I asked them about serotonin, I said, have you heard of serotonin? The vast majority of people say, yes, I have. Yeah, that's what causes depression, when your serotonin is low. So out there in the public arena, there is a huge awareness of what people have been told. But it's not true. There's no truth to that. None.
When you say it's not true, you mean there is serotonin, but the link between it can't be measured, the link between it and depression as such is not valid? Serotonin
is a chemical that is all over our body. In fact, the part of our body that has most serotonin is our intestines. What has never been come close to establishing is that there's any link between emotional distress or depression and serotonin. Utterly unproven. So that is just such a piece of misinformation that's out there. But when people have those kind of beliefs, it shapes how we look at everything in terms of emotional pain and distress.
So good information is obviously good information is obviously very important. Yes. Accurate information, or challenging maybe what
I think we need to learn to trust ourselves more. We need to trust that our bodies and our feelings, that there's a sense to them, and working things through. I mean, counseling and psychotherapy, working things through, talking things through in therapy, that has helped a lot of people. It's not for everybody, and there are differences in the quality of therapy. And again, as I was saying to you earlier on, Dara, one of the problems that has happened in mental health is that because the medical model dominates with bipolar schizophrenia in particular, therapists don't get as much experience working with people with a diagnosis of bipolar or schizophrenia. So their therapists don't get a chance to actually become expert in working with people with those diagnoses. So that is something that needs to change too, because they're seen as primarily medical problems. And like I said earlier, medication has its place. But there's no chemical imbalance identified for bipolar. There is no chemical or brain imbalance identified for schizophrenia. For any of those conditions, it's all misinformation. And the main drivers of that have been the drug companies. And many doctors have come on board with that idea. But that idea is essential to the drug companies because it legitimizes the widespread prescribing of these substances. As I said earlier, medication has its place. There are many people who would say that they have helped them greatly, and that is true. But if you look at depression, for example, the incidence of depression has gone from 1 in 1,000 people in 1968 to now 1 in 5 to 10 people. That's an increase of 100 to 200-fold in 32 years. And if we're saying that depression is a biological illness, that does not happen in human biology, that something changes that drastically in 38 years. It just does not happen. It just doesn't add up, I'm afraid.
So you're saying like the incidence of, say, diabetes or heart attacks or things won't have increased by that amount because they're a kind of a recognised and understood physical experience?
Yeah, it's actually, it just doesn't happen.
Yeah.
I mean, the incidence of diabetes has increased, but we generally know why the incidence of diabetes has increased. People are more overweight. So we have a sense of the why. But when you take depression, there is no sense of the why. That there has been this phenomenal, spectacular increase. But actually, when you break it down, by far the most likely reason is that it is how distress is being interpreted medically, and indeed now by the public as well. So the public are very aware of the idea of depression and often will bring that to the doctor. Doctor, I think I might be depressed, etc. And so it follows from that. But to me, it is fundamentally about accuracy. And I don't think depression, the word depression, sums it up properly at all. I think it's distress and should be looked at like that, from that perspective.
Okay, just taking that idea and, on a sort of practical level for, say, somebody working with distress, have you, some guidelines or things? I mean, I know Selfhood talks about this as sort of a manual for working with yourself, and you talk about affirmations and kind of rewriting or writing. And can you talk a little bit about how you might, as a person, kind of start to work with yourself a bit more?
Sure. Well, I think it might sound like a funny word to use, but I think acceptance is a starting point. Accepting that this is how I'm feeling. And then it's like, okay, well, where do I go from here? Again, it sounds like a cliche, but sitting with it, as in listening to it, connecting with what it is you're experiencing. Writing about it can be good therapy because it's a form of expression. I have found in my work, and the reason I wrote Selfhood is that a recurring theme, whether it's depression, diagnosis of depression, bipolar, schizophrenia, whatever the diagnosis is, one common recurring theme is what I would call a loss of self. And I use the word selfhood because it's often, self-esteem is a word that's often used as, well, it's happened because a person's self-esteem is low. And I began to realize over the years that that's not an adequate description of what's actually going on. There's a lot, in Selfhood I have about 30, 35 kind of aspects of self, and self-esteem is only one of them. And actually, funnily enough, I have often found with people that their sense of self-expression can be quite knocked, for example, or their sense of self-reliance, or self-belief, self-trust. These are just some of the themes I use. What I call self-generated security, which is the sense I have of being safe and secure in different places. That's a very common one in, say, schizophrenia particularly. People who have the experiences that end up being diagnosed as schizophrenia don't feel safe in so many places. So their sense of being able to generate their own security is very, very low. I'm just trying to explain why I use the phrase selfhood. There's much more to it than self-esteem. And I saw over the years that actually a lot of the people who I've met, even though their sense of self might be quite low, actually their self-esteem, for some, not all, but for some, their self-esteem is a little higher than some of the other factors because they often think, well, it shouldn't be like this. I deserve better. So their self-esteem is often not the worst, at the worst level, but often their sense of self-expression, their sense of empowerment, self-empowerment is often on the floor. So there's a lot to a sense of self. So working gently and gradually to recover one's sense of self is a core part of the recovery process. In my experience, action is very important. I mean, the defense mechanisms, getting to know ourselves better. Defense mechanisms are something we use a great deal, and most people who reach the point of a diagnosis are employing defense mechanisms on a regular basis. Common ones would be avoidance, for example, putting things off, avoiding a whole range of different things. That's probably the commonest one. And so I think being honest with oneself as well. Self-honesty is one of the things I talk about in Selfhood. Being kind and gentle and compassionate to ourselves. Recovery is a process that should be done very gradually, small steps. Support is important. We need to find, if we can, people to help support us. I think Renew would be a very good example of that here. What else? Action, yeah, taking actions. People, when we've been hurt and wounded, quite often we throw the towel in. You know, we just feel that, well, I can't, there's nothing I can do about anything. And I often find with people, well, it's like, well, okay, try something for 5 minutes or 10 minutes, and then stop. And often the action, William Glasser used to say this, the great founder of choice theory, that actually taking action is one way to change how we feel, and it's quite a fast way to change how we feel. So often we get caught up in our thoughts racing around, but we're actually doing nothing. And so if we actually say, right, it could be something as simple as, well, I'll wash the dishes for 3 minutes. And that very process takes me out of where I am into a different place. I'm now focusing on something else. And even 3 minutes, this comes back to what I was saying earlier on about the transient nature of experience. 3 minutes later, I'm not where I was 3 minutes previously. So there are a lot of little things that people can do. And empowerment is a very, very important part of it, becoming empowered. And quite often one of our defense mechanisms is to be disempowered, because it means taking less risks, and risks can terrify us if we've lost our sense of self. So it's a very delicate process, reclaiming our sense of self.
Terry, thank you very much. I'm just conscious of time, so I'm going to hand over to the audience to ask some questions and see where that brings us.
Of course.
So
could I just say, in terms of medication, I wouldn't, as I said earlier, I wouldn't want anyone to think I'm suggesting to anyone that they change their medication or come off medication. I'm not anti-medication. I am pro-appropriate use of medication. Sorry.
Thank you.
But often when we give advice, what we're actually doing, with the best of intentions, we're actually often stopping the person's telling us something, particularly if it's something we feel uncomfortable with. Sometimes we want the conversation to stop because we're feeling uncomfortable, and giving advice can be a way of taking the conversation off track into a different direction. And I think that one of the things I do more than anything else in my work is I don't interrupt. Well, that's not quite true, I do. But I certainly don't take people off track or give a whole lot of advice. I may, if a person's going off track, as in going down tracks of avoidance of what's real for them, I think, then I may gently try to bring them back on track. But just allowing people to be who they are and express what it is they want to express, and double check with people too. You know, people will often say, "Oh, I'm fine," and stuff. Well, is that really? Are you sure you're fine? That's the culture we've created. But we're all powerful. We all can make a difference. I wrote in Beyond Prozac, it's one of the things that pop into my mind. A man who was coming to me for a while, many years ago now, and he told me that, and he just said it in a matter-of-fact way. He said, Christmas Day, I was in the process of hanging myself. He lived on his own, and he was about to hang himself. He had the rope up and everything, and his niece rang and said, "Happy Christmas, Uncle." Said his name was Jim, it wasn't. "I love you." And he just burst into tears and took down the rope. That niece has no idea what she did that day, but she saved his life. Simple phone call. The little things really matter. Okay.
Terry, thank you very much. It's been a real
Thanks very much for engaging today.
So Terry and Dara, I think on just behalf of the festival committee and everyone here, just to thank you for such an engaged and enlivening discussion, and to say that there are books available, and Terry is happy to sign some books and to have a chat with people as well, I think. So thank you.
Thanks very much.
Thank you.